Today's topic is redefining priorities for health reform in a time of transition. We're very fortunate to be joined by a panel of great depth and breadth of experience, who all together will be giving about a half an hour of presentations. That means 5 minutes each, so we're going to try and keep it to 5 minutes of just an introductory framing remarks so that we can really move on to what I hope will be a lively and free-flowing conversation. So on to the panelists, who I will briefly introduce and then hand over the program to them. We have Michael Gelder, the Senior Health Policy Advisor to Governor Quinn and Executive Director of the Governor's Office on Health Commission and Transformation. Next to him is Julie Hamos, the Director of the Illinois Department of Healthcare and Family Services for another day. Yes? Yes, 2 days. Next, we have Judith GETHNER, the Executive Director of the Illinois Partners for Human Service, a statewide coalition of hundreds, I think, of human service organizations in Illinois, and a member of Governor-elect SHARON's Health and Human Services Transition Team. So some people like to talk. John Bowman is next to her, the Executive Director of the Sergeant Schreiber National Center on Poverty Law, and significantly the leader of the Responsible Budget Coalition. So he can tell us a little about some of what we already know, what we don't know, and some of the constraints we'll be working under, and what we can do about it. Then Nadine Israel, sitting next to John, the Director of Policy for Ever Thrive Illinois, which works to improve the health of women, children, and families over the lifespan. When I think of Nadine, I think of Medicaid expansion, but maybe that's just me, so maybe we'll hear a little. That which was listed as a priority by several people. And finally, we have Tom Wilson, the Community Development Organizer for Healthcare at Access Living, Chicago's Center for Independent Living, service provider and advocate for people with disabilities. So we're going to start off one after the other, 5-minute presentations, and then open it up to Q&A. We think we have mics, a mic on the aisle, and we'll start off with Michael.
Well, good morning. It's a very important topic and one that I've worked on for a long time. It's as we draw within a couple of days at the end of this administration. You wanted me to talk about the next round of funding from the Centers for Medicare and Medicaid Innovations. We were awarded a SIM model design grant early and got word of that in mid-December. We had asked for, money out of the model test site, but were kind of held back a year, if you will. Didn't get a social promotion in Illinois. We had a model design grant in 2013, and now we'll have another one in 2015 that they want us to use to prepare us to ensure that we will have, and their goal for spending this money across the country is that there would be 80% of the state residents receiving care from providers who are paid on a value basis and not a volume basis. And that's the essence of the change that they're trying to accomplish out of the Center for Medicare Medicaid Innovations to achieve that triple aim that was articulated through the Affordable Care Act of better health for the population, more effective, higher quality health care delivery, and lower costs, lower, at least more affordable costs through the system, because healthcare is still on the verge of being creating. It is creating distortions in the economy as costs for healthcare increase at a rate much faster than the other goods and services. So those three things, quality, healthcare delivery, and costs, are part of the goal, and paying providers for value rather than volume is the essence of that as far as CMMI is concerned. So Illinois has a $3 million grant They like what we're doing. They like the approach we're taking. They didn't think we had a plan on how to get to that 80% penetration, and that we didn't have our Medicaid 1115 waiver which had been stalled after the November election. So it seems to me, from what we can tell, those two things have contributed to contributed to them deciding to give Illinois a $3 million grant rather than the larger sums of money to test. We will be able to use that $3 million, though, to test on a smaller scale projects like the integrated delivery system pilot that we had recommended in our waiver both in our waiver application as well as in our model grant test application, the regional health improvement hubs, which we have no longer hubs but collaboratives that we have worked on together through scores of meetings through this summer and fall process of this engaging stakeholders to decide how we move towards those triple aims. Workforce changes that have been recommended as well, and the data and technology. So to get into the details of those, I strongly urge you to check the website. We now have the final report called From Innovation to Implementation, and it's a report of the work groups that have met so diligently starting in the summer. It's at healthcarereform.illinois.gov under the tab for the Office of Health Innovation and Transformation. And I'd be happy to answer more questions and get into more discussions about where we are and where we need to go, which is now in your hands with this report that's available to you as guidelines and a map as to how we get to that triple aim. So thank you.
Thank you, Michael. For now, let's move on to Julie Himmels.
So at Department of Healthcare and Family Services, you know, we've gone through amazing changes, and the centerpiece really has been moving our clients into coordinated care systems. And Michael started talking about that. Let me move on to remind everybody that this has been a time, and I want to acknowledge it, of great change and great upheaval and uncertainty and fear. The ground moving under you. I understand that for the providers in the room. It is, we think, a very promising approach because our clients really do need care coordination. They need they need networks of care, of collaborating providers who are going to pay attention to the whole body and really deal with our clients in a much more holistic way. That's been our goal. That's what we think we're going to get from this. We are in the process of now enrolling 2 million out of our 3.1 million Medicaid clients into some form of a health plan, and we've inspired some innovation. I'm proud of that. We think we're going to see the new group of accountable care entities, who are being organized right now by providers. They're just starting up, and it's a very new concept of really having providers work together to help really look at our clients and deal with them and provide that kind of care. Our managed care organizations are learning about a whole new market, a whole new population. And that population doesn't look that different in Medicaid than the ones that they're getting through the health insurance marketplace. So people who are buying health insurance with subsidies, a lot of them look a lot like our Medicaid clients, and the health the HMOs, the managed care organizations, are having to learn with a whole new group of people. We have care coordination entities who are really working with disabled and people with disabilities and seniors, very much a higher, more complex set of needs, and they're learning how to work in a very new kind of way. Those reforms are here to stay. This is the new world of Medicaid. I believe that the new administration believes in this and will, if anything, move it forward in some new ways and maybe some novel ways, even beyond what we may have thought of. But here's what I think needs to happen now in this new space, in this new next step. Those three kinds of entities, the care coordination entities, the MCOs, and the ACEs, need each other. The ACEs, provider organized, need to develop sort of the expertise of the MCOs in learning how to do data analytics in learning how to manage members' needs and treat our clients as members. But certainly there's a set of back office supports that we think that would be beneficial to the ACEs if they really collaborated and now partnered with MCOs. The MCOs certainly need the ACEs and the CCEs because, again, they're learning about a whole new population. People, they're learning about social determinants of health very much on the ground now because they see it with the clients, the members that are signing up for their health plans. So they need the community providers, they need the collaborators who know how to work with people, who have, feet on the ground in the communities, and we think those partnerships need to happen. And we are also rolling out, and you will hopefully see this on our website the next day before I leave, a concept paper for health homes. We're going to apply to the federal government to move a state plan amendment to bring health homes into Illinois. Probably 9 months from now, 8 months from now, enough time again for these to get established. They will fit into that managed care system that we've created, but the health homes, again, made up of community providers, CCEs, to provide real high-touch services to people with complex needs. That's what that's about. So the collaborations will continue. They need to continue in some new ways with some new partnerships, and we really encourage you in this audience to take that message back because you're very much needed as we move forward with the managed care rollout. Thank you.
Thank you, Director Hammonds. And thank you for passing down the mic. I was about to ask for our friends at CAN TV to just pass down those mics so it's in front of whoever's speaking. Now Judith GETHNER can speak to the human services perspective, which segues nicely from Julie's comments. Thank you.
Good morning, and thank you again for inviting me to speak. My name is Judith GETHNER, and I am the Serving Executive Director of Illinois Partners for Human Service. We're a statewide coalition of over 800 nonprofits around the state of Illinois that serve over 2 to 3 million people in our state, and as Director Hamos mentioned, the integral part of the success of what's going to roll out with healthcare transformation and reform. I was honored to have been selected by Governor-elect Runner to serve on his healthcare and human service transition team. We have completed the work that we have done. There were 20 of us that were selected around the state. We were supported by McKinsey, who worked as the support staff, if you will, behind the scenes for us. We had one of their senior partners and probably 5 to 6 of their staff that worked with us in a pro bono capacity. The meetings that took place were very, very targeted, very directed. We were given an assignment prior to our first meeting, and we were asked to answer some questions that they wanted to understand from us what kind of risks and opportunities there were within healthcare and human services, and what might be what they identified as low-hanging fruit that they might be able to impact within their first 100 days of administration. After our initial meeting, where we were able to learn from each other what all of our perspectives were, the McKinsey team did yeoman's work meeting with, on the phone, meeting with probably 100 additional stakeholders around the state to get their input. And so that when we convened again for our next meeting, not only was our input on the walls for us to discern, but so was the additional 100 folks that had given their input. And the next project that we were to undertake was to look at what had been compiled as the recommended policies and strategies for healthcare and human services in Illinois, and to rate it, to provide them input with what might be risks on some of the strategies and also what might be opportunities, and what might be things that they completely missed and were not even on the walls, if you will, because it was literally walls of recommendations that we walked around and gave our input on. The 2 days after our meeting, the McKinsey group met with Governor-elect Runner and provided him with the input that we had given in our work group, And then the follow-up was to be a document, a written document of all of the work that we had done, which is being provided to him this week. And so my hope is that when a combination of things. One, that when we hear his address next Monday, when we hear his State of the State address in early February, and then most importantly, when we hear his budget address the third week in February, my hope is that a lot of what we had provided as very substantive, concrete, measurable result recommendations will be seen in this. There was certainly a real openness and a willingness to listen to us. The people who have been hired, the staff people within the transition team, are not people that know about this work. And so their looking to us as subject matter experts was very obvious, and yet was very, very respected. And so I think the entire process and participating in it was very rewarding, and I have very much high hopes for what the next steps will be. I want to now give you my personal bias and opinion of what I think we all need to do based on everything that I just said, and what my gravest fear is. Okay, so I'll be more dramatic then. So the gravest fear that I have is that those, and I now speak specifically to the world of human services, which in our budget, both state and national budget, kind of engulfs about 15 different silo areas of service. My fear is we're all gonna go back into our silos, and we're gonna start fighting again against each other with this new administration. What do I mean? Folks that care about seniors are going to start fighting folks against who care about childcare, who care about domestic violence, for those who care about after-school programs, and on and on and on. And my fear is that when we get worried and get concerned, we go back to our old way of acting. And the work of Illinois Partners has been to put us together as an umbrella to fight on behalf of the people that we serve, who do not get served and do not live and will never survive in the silos that we deliver service. They will only survive if we all collaborate and work together, which really speaks to what Michael and Director Hamo spoke about, which is this integrative delivery system. We can't go backwards and now meet a new administration and educate them without talking about the entire sector and what we need to do in order to lift up and raise the health care of people in Illinois. Thank you.
Well, thank you. Now, John Bowman.
So I've got three things, three categories of things to talk about. One is a little Julius Caesar speech. Two is what to look for and be afraid of in the budget. And three is, very briefly, a couple of things about what's going on the federal level. First, the Julius Caesar speech. I don't come to Barry, Mike, and Julie, but to praise them. And I don't think we do that enough. I think it's important to do that for two reasons. One is because they deserve some high praise, and two is because if we want to preserve the good directions we have, we can't be shy about naming and celebrating what is good and what needs to continue. And if you took snapshots from 10 years ago to now, you'd see probably at least 1 million more people with coverage. You'd see that Illinois is among the states that did the Medicaid expansion, with Republican governors all over the country making the profoundly against interest decision not to do the Medicaid expansion. There's an attitude of everyone covered, a courageous defense year in and year out of the coverage for undocumented children and all kids, a national lead in enrollment, both the training of the enrollment personnel, the troubleshooting, the constant improvement attitude, and the results. Illinois is among the very best. Vigorous improvement of the application delay situation that arose around the flood of applications that happened when Obamacare went live, and rapidly fixing that through hiring and paying close attention to it. Care coordination. We have a bad, troubled history of managed care in Illinois, It took a lot to shift to good managed care, which is care coordination, and to get people to try to trust it. We're working on all that, but it is the right direction if it's done right. And I think the things that are underway are in the right direction, and they're doing the right thing. The attitude of innovation, the culture of everyone covered, first focuses on health outcomes and not on budget, and thirdly, an attitude of constant improvement and not the sort of bunker mentality of once you make a decision, you can't change it. And so I want to just take a moment and appreciate the work that's been done, urge us all to not be bashful about it, urge you guys not to be bashful about it, and to just let's put our hands together. Secondly, the budget. I'm out. Okay. The budget is, we're out of money. If they don't find revenue solutions, what is threatened is Medicaid is a big pot of money. So if you don't have revenue and you have to balance a budget, there's very few other places you can go to make cuts. It's just a relentless logic to it, even without the ideology and politics. So we have to push for adequate revenue in the budget, or we're going to see problems with staffing that have plagued both of the departments for years. Not enough staff to do very important jobs. Rates might get cut. Covered services might get cut. Eligibility could suffer, including the perennial challenge to coverage for children, regardless of status. We'll see a lot of churning, this waste, fraud, and abuse cover story for just cutting off eligible people, and then bad privatizing and bad digitizing, computerized eligibility terminations and so forth. So keep your eyes peeled for that. There's a high stakes in the budget, and we need adequate revenue. Lastly, on the federal level, never support a Medicaid block grant, but we'll see it from Paul Ryan and others. And two, reauthorization of the Children's Health Insurance Program is extremely important.
I think you actually banked a little time there, and I'm sure we wanted to talk a lot more about all of those topics, so thanks so much for the concise summary. So Nadine Israel.
Thanks, Sharon. Again, I'm Nadine Israel. I am the Policy Director at Ever Thrive, Illinois. We used to be the Illinois Maternal and Child Health Coalition. We are an advocacy organization, for those of you that don't know us, who focuses on improving the lives of women, children, and families. And so I just wanted to echo a lot of the comments that have already been made by John and other folks, and focus, I'll just take like a couple of minutes on sort of really remembering all the progress that we made in terms of healthcare reform. So not only reforming our Medicaid system, through changing the delivery system from fee-for-service to care coordination or managed care, increasing access to health insurance through Medicaid expansion. We can't forget the huge cuts that were made in 2012 with the SMART Act, but we did restore a lot of those last year. So protecting, for example, the dental services that were restored for adults recently, and other services that were also restored. So those are things to sort of keep watch on from our perspective, from my perspective, coming into the new administration. And echoing John's comments about looking at the federal level, so there's been a lot of proposals that would definitely impact the Medicaid program and other programs in Illinois, especially block granting Medicaid, for example, which we would never be in support of, but other ways of block granting that isn't called block granting. So just sort of from our perspective, from my perspective, we sort of both need to be watch at the federal level in terms of what's moving, as much as we are watching what's happening at the state level in terms of budget and other policy changes. The other piece that John mentioned is the CHIP authorization. So the Children's Health Insurance Program, it's authorized through at the federal level through 2019, but actually the funding for it runs out, again, at the federal level at fall of this calendar year, fall of 2015. So again, at the federal level, unless it's appropriated for a few more years, then states need to make certain decisions about their CHIP program. So that's something that's very important to our organization, but also that's going to impact lots and lots of hundreds and thousands of kids in Illinois. So again, that's something to keep watch for. And I'll stop there.
Thank you, Nadine. Moving on to Tom Wilson.
Hello, everybody. I want to begin with a few consumer stories. I want people to be aware of some of the unintended consequences of the Medicaid managed care. A disabled consumer I know was shocked to find out that after being enrolled in managed care, that when he went to his neighborhood pharmacy where he knew all the people, that he was no longer able to fill his prescriptions, and he didn't know why. Another person I know was getting their home care services through the traumatic brain injury waiver. Her counselor worked for the Traumatic Brain Injury Association, and she had a person who was well-versed in traumatic brain injury issues and was passionate about her work. After being enrolled in a managed care program, she found she had a case coordinator who knew very little about her disability and who was not passionate about her work. Another story comes from the Managed Care magazine online. It's about a consumer in Illinois with HIV. The person, who was legally blind due to the complications of HIV, had used doctors at Howard Brown for his care, but they weren't in his managed care plan, so he was assigned to a practice closer to his home. If you Googled the doctor assigned to him, you saw that the web page showed that he focused on bariatrics and promoted OptiFast weight loss products. Not the doctor you want if you have HIV. These are examples where continuity of care has been interrupted. This was something we warned would happen and have seen it happen. I think these issues resulted from consumers losing some control and choice over their health care, and we consider that to be very important. I also want to talk about long-term care services and supports, and with not being clear what's going to happen with the 1115 waiver, I'm going to comment on some things that are still likely to move forward and we think are important. Illinois has been very slow to rebalance long-term care, and it still ranks quite low. We do have the 3 Olmstead lawsuits, though, the Ligas, Williams, and Colbert, and they're continuing to be implemented, of course, and they are moving people out of institutions. There are new federal rules out there mandating greater consumer direction in long-term care and in person-centered planning, and Illinois, to comply, will need to be implementing those. Illinois also received the Balancing Incentives Program grant from the federal government. This is called the BIP, and it already is federally approved. And it includes some things like no wrong door for getting services, conflict-free case management, and the implementation of a uniform assessment tool. All of these were adopted into the 1115 proposal, and we think that they are valuable and should be implemented and moved ahead as we go forward. There's still a need for better community services, home and community services for seniors, people with psychiatric disabilities, and there's a waiting list for community services for people with developmental disabilities. And these issues are not going to go away. Also, disability advocates continue to support the Community First Choice option, as it would help Illinois rebalance. It's a 6% enhanced match on community services. And we would see it as very compatible with the 1115 policy goals. I wanted to talk a little bit about social determinants of health. It is well researched that a person's income, social status, race, education, and other markers are significant factors in health. Other research has shown how influential the ACEs are, adverse childhood experiences, and they affect people as they age. If you have like three or more of these, you're very likely to have early onset of chronic conditions such as high blood pressure, diabetes, and mental illness. Some of the ACEs include things like experiencing emotional, physical, or sexual abuse as a child, domestic violence in the home, substance abuse, incarceration of a family member, and so on. Anyway, we know from research that poverty kills. We know that a very high percentage of people with disabilities live in poverty. If you get Medicaid, that means you're living in poverty. Okay. So we also know that the U.S. is increasingly economically unequal. And this inequality is driving our health care in the wrong direction. It means we will have more health problems as we move forward, as more people are living in poverty. So that's a huge thing, and we need to try to address that if we really want to address the healthcare issues in Illinois. And finally, I just want to mention that we know that other countries get better health outcomes, and they pay much less of their GDP for healthcare. And how do they do this? It's by having a national system of healthcare paid through progressive taxation. And being a single payer supporter, I think we need to promote this in every way possible, and that this is the only, well, it's a necessary but not sufficient way to address health disparities and inequality in this country, and I'll leave it at that.
All right, thanks to all the panelists. We do have a microphone in the aisle on my left, your right. So if you have questions, please feel free to either shout or go to the microphone. Having looked at the priorities that people identified on the registration form for this forum, wanted to be responsive to those and just ask one question for the panel to start off the conversation, because it was the top theme when we categorized them was access. But the second was closely related, was mental health. People were asking about the parity law. People were not asking about, but highlighting about integration of mental health with physical health, about mental health for people who are just as involved, mental health for children. It was definitely a priority for a lot of people in this non-scientific sample. Except a few comments that Tom made, it didn't come up explicitly, but since it had come up so much from people who were took the time to actually fill out the form and everything, and probably many of you are here, I thought if anyone on the panel would like to talk about, in the sort of spirit of what we've been talking about today in general, what reforms might be happening now that could improve mental health, where we see them going, what people can do without waiting on Springfield right now to try and help improve, I think what we all recognize is a very inadequate system for mental health care for both Medicaid and non-Medicaid individuals. So if anyone has something to say about mental health, I thought since it came up so much, it'd be great to address it. And unfortunately, very often it does get marginalized. So I thought if anyone wants to take that on.
I don't have much to say, Sharon, but let me just tell you, it was noted and re-noted and re-spoken very, very frequently during the transition meetings. So I want to rest folks assured that if nothing else, this was not something that was neglected in any of the strategic goals that we were all asked to rate and give our opinions and risks for.
I would talk a little bit just about medications and mental health. And a recent study I saw showed that even small or not so small differences in co-pays can affect people. And we know that among the right, one of the philosophies they think is really important in healthcare is having skin in the game. But the research that I saw showed that people who were using geriatric drugs with much lower co-pays were having significantly different survival rates than people who were using the name brand drug, because there wasn't as much compliance with taking the medication. And in the mental health field, I think that's a very serious issue for many people.
And I will just add that when we started down this path of a care coordination or managed care rollout, really in 2011, we were the first ones, I think, to recognize that all of the health plans that were being organized needed to include mental health services as well as substance abuse disorder services. And we pushed that, again, that very early collaboration in two departments, because our sister agency at Department of Human Services typically has been the subject matter expert on mental health and DASA, but we really partnered right from the beginning. And from the beginning, all of those health plans that were forming, again, it didn't matter if they were CCEs or ACEs or MCOs, complained that there was not enough capacity in the community for either one of those. So building up the community-based service system has become a very high priority for the Quinn administration. I think the centerpiece of the 1115 waiver really was to take some of these costs that we have been using GRF to pay for and reinvesting in those kind of community services. So if the 1115 waiver, and using federal dollars as match to be able to really expand our funding base. So the new administration, I hope you will all work to talk them into moving ahead on the 1115 waiver. That really is a way to expand our funding base and to make that kind of reinvestment in the community services. And short of that, and with a terrible budget situation on our hands, I don't know how we're going to do that. But capacity is obviously a very big need. Everybody acknowledges it, and we all need to work together to improve that.
And that was, oh, sorry. Oh, well, the mics are here, so, yeah, and I don't want to detract, that Julie just said that very, very well. I would also draw your attention to the concerns about children's mental health services, which are developed very fully in this last report that got posted yesterday, where the work group on sports and services and the subcommittee on children's mental health services delve very deeply into what the state needs to do to develop and enhance a system for children's mental health, because as we know, as adults, a lot of these children, a lot of the adults suffering also had experiences in childhood that, had they been addressed more fully, would lead to many fewer problems in their adult lives. So the system of care is the rubric, the proper noun for the program that they endorse, and if we're interested in that, I really urge you to look at that and try to make sure that that sort of effort continues into the next administration.
And let me just say, I'm so glad you brought this up, because children's mental health is obviously so important, but there's a lawsuit. So once again, the class action is going to push this agenda. Right now it's called NB versus Hamas, where I was a defendant rather than a plaintiff, which I wanted to be. And luckily, that's going to change. It's the only good thing about me moving on, is that there will be a new defendant. But NB will become, I think, the movement forward in really dealing with the children's mental health issue. And right now, there has been so much work to get us really a consent decree in place and a plan, and that is going to happen. Now, with the federal court monitor watching over us, I think the new administration is going to have to embrace this. The question is how big and whether this will really be the effective program that we had envisioned. So keep your eye on that and help move that along too.
I just had a quick comment about funding, both sort of for mental health and in general. So when thinking about lots more folks having access to health insurance, whether it's through Medicaid or private health insurance on the marketplace, one thing that's been talked a lot about, especially through the 1115 waiver conversation, is that a lot of the funding that is GRF, so General Revenue Fund funding right now, state-only funding, isn't necessarily needed anymore now that folks have access to Medicaid and can get, for example, mental health services through Medicaid. So one thing for our organization, and so from my perspective moving forward, is that while there are services that Medicaid covers for mental health and other services, they're still not fully covered by Medicaid, and not everybody qualifies for Medicaid still. And so in terms of funding, state funding, from our perspective, even if we get the 1115 waiver and if the new administration pushes that forward, it's really important to preserve some funding, some state funding for services like mental health, substance use treatment services, and lots of other services that may become medicized and move into Medicaid. We still need sort of a pot of money for those services for the folks that can't access Medicaid still or don't for whatever reason, and also for the services that still aren't covered by Medicaid. So that's sort of the one point that I wanted to add.
Yeah, that's a really good point, thank you. So if the panel's done responding to my initial question, they have plenty of questions lined up on the aisle there, so we can get started. And you can ask, and people should feel free to respond to each other's questions. I think we have a lot of expertise in the room. But yeah, please identify yourself and your organization so we know who's talking. And then that way people can get together afterwards and actually do something.
My name is Ann Sheets. I'm with the Illinois Single Payer Coalition and Physicians for a National Health Program, and I and my colleagues have brought a handout, myths and facts handout that we hope you will take from us after the program, challenging the assumptions that underlie the whole concept of forcing people into managed care organizations. I do have a question for Ms. Hamos, but I want to preface that by saying that some of the claims that are made that are not supported by the evidence and are often refuted by the evidence are that fee-for-service is a cause of increased costs, not true. That some kind of focus on value and rewarding people for that improves quality or decreased costs, not true. It often does the contrary. It causes harm. So these things sound like they're good ideas. It turns out that in practice they do not work as they are said to work. The claim that HMOs or other kind of, quote, managed care improves costs or decreased quality, not supported by the evidence. I'm thankful to Tom for bringing up the fact that a single-payer system is a necessary but not sufficient condition for healthcare justice in this country. And my question for Ms. Hamos has to do with the idea that managed care organizations or these various names promote, quote, integrated care, when in fact what we see is that they disrupt care by forcing people to leave their providers and be siloed into these narrow networks that are created by the managed care organizations. So I would like to know whether you have this data available. What percentage of the patients who were forced into these managed care organizations had to change hospitals, had to change physicians, had to change pharmacies, had to change home health agencies, and what percentage of people who were required to get pre-approval if they had to take more than 4 drugs, what percentage of those people had waiting times in order to secure their prescriptions? Thank you. And again, I hope people will take our handouts afterwards.
Yeah, I've actually not said anything about costs, by the way, and saving money. What I have said is better care, because I do think that the fee-for-service system doesn't work for one very important reason, which is that it's a completely fragmented system with providers working on their own to provide care one part of the body. So if you're there at 2 o'clock for even a general checkup, that provider is not going to ask you about your mental health care or your substance use needs or anything else. I mean, it's really just the provider system itself is so siloed that it's not the best care in terms of a collaborative model. And I have not said anything about saving costs as a reason for doing coordinated care. I have talked about higher quality care in terms of better health outcomes. It's exactly what Michael talked about. That's the vision. Are we there right now? No, we're not. And that's why I talked about the future being much more collaboration among different types of community agencies and providers, but it all has to fit within a network. That's what I really believe in. That's what I think will produce a better system of care. Now, I wanted to respond. The choice issue is really an important one here, because we want every single one of our Medicaid clients to have choice and to exercise their choice. A lot of our clients don't do it. They don't open their mail or they don't respond to their mail, and it's been very difficult, especially in this first round of a rollout, to really have every single client to understand a complicated system that got put together. In part, it became more complicated because there are so many different health plans. I mean, that's the positive side of innovation is that we have a lot of health plans. The negative side of innovation is that there are probably too many from which to pick. It's happening in the health insurance marketplace also. How many health plans do we have this go around? 400 or something? So we've created a complicated system. There are lots of choices. I will tell you that half of our clients, or 48% of our clients, are making a choice based on what they know, where they're, the kind of choices that you and I make about which health plan we select. We look at who the doctor is. We look at which hospital we want to go to. We look to see if a specialist happens to be in a health plan. We figure out which one's the most important, and we pick a health plan. And that's what we're asking our clients to do. Choice is really important. If we got 100% of our clients to choose, that would be the best. That would be the best possible outcome. I think over time, when people get used to this new system, there will be even more choice exercised. But I acknowledge that sometimes in this first go-round, there was some confusion. On the other hand, if you want to go to Howard Brown and you got assigned somehow to a different doctor, you can switch back to Howard Brown. So we want our clients, and we want you to tell your clients and our clients that they also can exercise their choice back to the place they want to be, because continuity of care and really getting health care is the most important part of this. And that if there's some place that people will go for health care, that's the top priority.
Just turn it. I would just also add that we've been very concerned about the impact of the move towards coordinated care and its impact on quality and outcomes. And since the beginning in 2012, we started a evaluation project with the University of Illinois here, right here at the Institute for Human Development, Tamar Heller, and their research following the clients in the integrated care program, which was our first rollout, are published. They're doing year 3 now, I guess. We have years 1 and 2 behind us. And there were challenges, to be sure, but even in year 1, when providers were kind of boycotting the program, we were still able to, their evaluation, of which several people here have been a part of that stakeholder group, the advisory group, did demonstrate reductions in hospitalizations, lengths of stay, emergency room utilization, some things that are also very important to the disability community. So yes, there are disruptions, but there are also some positive outcomes. And we need to keep working, and that's why this evaluation is out there, so that we can all keep working to make it better.
Well, yeah, thanks for that. I think, I expect we'll have more conversation about this. And I appreciate that you plugged that, the report from the UIC evaluation. They actually did look at prior authorization and how often prior auths were approved or not approved in the timeline. So it's a really in-depth report for year 1 and year 2. And I think they're doing really wonderful work to look and see what's working and what's not. And that helps improve. And whether you think we ought to be on the managed care road or not, I think if, like Director Hamo said, if these reforms are here to stay, we want them to work for the people that that they're attempting to serve. And the IDPH funded UIC conducted evaluation of the integrated care program is just invaluable, and I think it doesn't get enough attention. So check it out. And if you want to look at prior authorization for both drugs and non-pharmacy benefits, it's in there. They did it. They looked at the data. So I wanted to make sure people had a chance. There are a lot of empty seats and people standing, so people should feel free to sort of to find a seat, or if you're planning to ask a question, that's certainly okay too. But we can have people fill in some of those seats if they'd be more comfortable. We do have a little more time left. So anyway, but in the meantime, we have lots of questions. So let's move on. Can you please identify yourself and your organization?
My name is Deb Hamilton, and I don't belong to an organization. I'm a mom. I have a daughter who is an adult. Can everybody hear me okay? Yeah. Okay. A daughter who's an adult with disabilities, and when she turned 21, a few of you have heard me speak already and know that when my daughter aged out of special education, I turned my back on my career to stay home with her. Gave up 75% of my pay and some great dental benefits and a retirement plan, so that I could be her personal assistant at home. That worked out very well until managed care got in on the act. And I need to share, before I ask the question I have, I really need to share a story that I'll try to do quickly. It's a very small piece of this whole picture that we're talking about today. but for my family, it's a really big thing. Everything that I'm telling you is factual, and I'll try to condense it so that I'm not standing here all day. When my daughter, in the old days before managed care got involved, we had one-stop shopping with DRS. DRS would come into the home, do a DON assessment, and very quickly draw up a monthly service plan. And boom, one visit, and we were done. Now that it's been bifurcated and DRS comes in and does the DON assessment, I have to schedule another appointment for managed care to come in and to do the monthly service plan. So that's what happened for the first time in October. On October 15th, DRS came into my home to do the DON assessment. It was an increased score over and above what my daughter had had before, which we had felt in the past had been artificially suppressed. So that was good. On October 27th, managed care came into my home. Here's where things got really rugged for us. Because managed care is trying to contain costs, it was obvious to me that their job was to reduce my daughter's service hours. And this is how it was done. At first, the representative said to me, I can't give your daughter more than 7 hours of care a day. And I said, really? That's news to me. I've never heard that before. Are you sure? And she said, well, maybe I could give your daughter more than 7 hours a day in care. My daughter needs constant care. I can't leave her alone. So when I revealed to her that I knew the service cost maximum and that I had already done the math and I already knew the monthly service hours, then she backed down from that claim that there was a cap, a daily cap on the care. So then she said to me, okay, well, you did the math, but you divided the service cost maximum by $13 an hour, or excuse me, by $12.25 an hour, which is what you're making now. But in a few months, you'll be making $13 an hour. So we're going to divide the service cost maximum by $13 an hour. And I said, no, we're not. $12.25 an hour is what I'm making now. We're going to divide the service cost maximum by $12.25 an hour. That would have reduced her hours, but I was able to draw the line with the representative. The next thing that happened was she tried to post-date the agreement for 2 weeks into 3 weeks into the future, so that the state could save a few $100s. And I said, no, you're here today. We're going to date this today. So I was able to finally get a service agreement that was suitable and that what I had expected. She left, and I found out that she had, in the end, reduced my daughter's hours, even though I had signed an agreement, even though her hours had increased by the agreement, it was reduced. So I filed an appeal with DRS, with DHS, and for a request for a hearing. On November 17th, I withdrew that request because they did restore my daughter's hours after the appeal had been filed. On December 14th, I got an email from our managed care representative, and she said, we're going to have to reduce your daughter's hours because there's a new policy limiting the number of hours per week to 40 hours a week. And I was aware already that the Department of Labor had put in some overtime rules. I knew that. But I also knew that there was a 6-month extension and that Illinois had not decided what to do about that new ruling. So I told her, this is not right. Illinois has not decided yet what to do. Then I got another email from our managed care company on December 15th, and she said that I would have to hire another PA, that I couldn't do all the work because of the overtime rule. And again, I said, no, that's not correct. I'm her mother, I'm her caretaker, I'm happy doing that. I gave up my career to do that. I can do this as long as the ruling has been made. And then, this is the big finish, on December 19th, I got a Christmas card from our managed care company. My own mother doesn't even send me a Christmas card. Why are we spending our money this way? there was a postage stamp that went into this, there was printing that went into this. I don't want this. I want honest care from my daughter's managed care company. So my question to you is, who's going to ensure that the managed care company is ethical? Who's going to babysit for them? So far, it's been my job, but I want to care for my daughter. I don't want to babysit for a managed care company. So I'll leave this to all of you. Who's going to watch them while they're watching us?
Well, thank you first of all for sharing your story. It's not always easy, and there is a whole catalog of breakdowns there, right? So I think it's worthwhile to think about what broke down and how, because that's up. I mean, and thank you again for sharing your experience, which was a bad experience. But that's, I think, what every step of the way there was some breakdown, and it should, like I said, shouldn't be on the consumer or the family member at all times. So but I feel like we could probably make a generalization of each breakdown and sort of be keeping an eye on that so that doesn't become a pattern, or maybe it is, but so it doesn't become sort of the reality for everyone. So thank you for sharing that. And we could certainly take time here to identify where those sort of systematic breakdowns were, because that experience, it erodes trust, it erodes the foundation that we're trying to build no matter what our position is. So does someone on the panel, anyone want to respond to that? Maybe John does too, but Tom?
Yeah, just briefly, I want to note that the federal government did change the overtime laws because PAs weren't making overtime over 40 hours. Well, you know, I think if you believe in disability rights and human rights, you believe in workers' rights. And workers should get overtime if they're working more than 40 hours. Now, whether we'll see the state agree with that in the upcoming administration, I do not know. But the reality is that there has to be some very strong oversight on this. I know in Texas, people lost home service hours because some managed care plan felt that they were losing money on home care services. And so, you know, we need to be very vigilant. And as I think you can tell, many of the consumers are not going to be as sophisticated and able to fight back as Deb was able to do so. So people can be adversely affected even, you know, because they don't know how to respond to all of these things.
While the mic's going down, I would just recall Tom's phrase, unintended consequences, and that these are unintended consequences. So without having to have every consumer, every family member have to go through all the work that Deb went through, again, that'd be good to identify how that happens and make sure it doesn't continue to happen. Because I think we can agree that at least they're unintended consequences.
Right. Well, I just wanted to add, I mean, I think no matter where you are, if it's a family member, if it's myself or a family member of mine, people in this audience, we all know that the most important thing probably the most important thing in the healing process is having an advocate and managing with your own resources within your system, whether it happens to be fee-for-service or, you know, the negotiations with your payer, the negotiations with the state. If the state is the payer, we always have to be good advocates on our behalf and have somebody with us throughout the process to make sure that the system is indeed working as well as it can. So I applaud the family advocacy. That's really what our whole system is based on. But in terms of who's watching the managed care, the state, the contractor is. I mean, the state has a very vigorous and very rigorous requirements that are imposed on the managed care entities in terms of how much money they have to devote of the premiums of the dollars that they receive from the state to the care of the individuals. And if they don't provide enough care to meet those percentages, they give the money back. So there's no profiting from underserving clients in that way. If that worker who came to the home felt that she was doing her company a service, she probably wasn't. And when there are problems like that, we need to know, the appropriate agency needs to know, so they can raise the problem with the state's contractor and get that corrected. So the state has a very vigorous oversight role that we play in terms of medical loss ratio, the overall percentage. We also employ a outside review organization that comes out and does audits of care plans and of the care that people are receiving to make sure that the managed care company is indeed complying with the rules and regulations and achieving the appropriate, that they're following the appropriate care plans. The governor is a supporter of workers and workers' rights and did support the 40-hour work week rule. And it is having consequences. I don't know if they're unintended. The idea is to pay workers adequately or not force them to do overtime at rates less than time and a half. But it does disrupt the system that we had, on which we were relying on caregivers to provide more than 40 hours and not paying them overtime. So that's something that the system has to adjust for, and it's in the process of doing it, and hopefully the new administration will continue the respect for workers' rights that Governor Quinn believed in as he was governor for the last 6 years. But we take that responsibility very seriously and do everything that we can within state government. And when there are problems, if we hear about them, we can act on them. But it doesn't mean that everything stays the same. There are different plans, have different providers and different approaches to care management and care coordination and the delivery of service, and people can choose among those plans to find the plan that has the best system for them. That's the idea of choice that Julie talked about earlier. I wouldn't ever underestimate I can't overestimate the value of self-advocacy. That's always important for each of us.
Another question?
A response.
Just identify yourself.
I'm sorry?
Would you identify yourself first?
Of course. My name is Scott Nance, and I work with Tom Wilson at Access Living. And in response to Deb, I'm also a Common Community Ombudsman. It's a new program funded by the state through the Department of Aging, and we do serve as that oversight, as that part of making sure the managed care organizations are doing what they're supposed to be doing. So for anybody who's not heard of that, I'm going to jump back in line and ask a question about this. But I'd love to meet with anybody and everybody to talk about more about that later. But just wanted to tell Deb and anybody else who's out there looking for that advocate, that's what we do. And at Access Living, we have 30 years of experience of doing this anyway, except now we have a badge, and that makes a difference.
I just want to add something real quick. Since the topic today is sort of what's going to happen in the transition from one administration to another, I think it's so unlikely as to be almost impossible that the new administration is going to reverse course on the transition to managed care. So I think we spin our wheels a little bit. I mean, the advocacy should be done about, if you don't support managed care, but where I think the things to watch for aren't necessarily, whether you're going to be successful at that, but these issues, right? Is there going to be a watchdog? Are the agencies going to monitor the contracts with the managed care agencies so that they comply with things? Will there be adequate due process? The availability, clear notices, the availability of hearings, the right kind of rules that you can at least cite to correct a situation that went wrong. So I think the thing to watch for is how will the new administration monitor and implement managed care, not whether they'll stay with managed care. And I think that's the stuff to be especially attentive to going forward.
Can I say one? The other thing that I was just going to add to what John said, and that was exactly the comment that I wanted to make, is as advocates, our job is to, at least from my perspective, is to work on increasing transparency. It's still pretty hard to tell the real difference between the different options when it comes to the managed care that we have available right now. And some may be better at certain services or serving certain groups of people, but we don't know that yet. And so some of that is going to become with sort of experience and word of mouth. But the more we can push the new administration to make data available and be more transparent about who's paying for what and how much they're paying for it and what they're covering and what needs prior authorization and what pharmaceuticals are on a step therapy and what pharmaceuticals you can just get when you need them. All of these things in terms of access and services are crucial. And we all know this, but it's sort of right now we're not quite there yet. And I think in terms of moving forward and looking forward, that's part of the advocacy that we all need to do together to push for more transparency on these things. So it's easier when a consumer is needing to make a choice between different managed care entities of which one is sort of going to be best fit for them. Also, it'll be easier for the state, as they've already done, to put sanctions or correct things are not happening the way they're supposed to within managed care.
Thank you. A question from John.
So my name is John Jansa. I'm a consultant working on Medicaid waiver and home community services. I have a question really focused with Judith and your comments. First of all, I certainly appreciate having worked in the disability arena and worked within collaborations between aging and disability. I appreciate your comments about sort of the bunker mentality that could occur going forward in terms of fighting for everyone feeling like they need to fight and reestablish their presence within the health and human service spheres. I would want to just highlight a comment that Tom made about under the BIP, that the state is endeavoring to work on a universal assessment tool, which could do a lot towards bringing a lot of different agencies and organizations together, working under one tool to assess individuals for all the different services that they're eligible for and addressing the social determinants behind their living situation or their situation in the community. So I want to bring that up as one way to move things forward. And then I also want to you probably didn't get enough time with your 5 minutes, and since we're all friends here, I thought maybe you could, if you could share a little bit more, however much you're willing to share, about the actual proposal you put together for Governor Rauner and his team, and what issues you may have presented to him for him to look at moving forward.
Thank you. Well, once I heard that we had a TV station here, it totally, last night, changed my remarks. Because we were asked, and I'm sure you all can appreciate this, we were all asked to keep the work that we did confidential. And so, I appreciate that as they're getting themselves prepared for what their remarks are going to be. I think once we see what Governor-elect Rauner says, I think that changes the game, but we're not sure yet. So I think that was one of the reasons that they've kind of asked us to, if you will, embargo what would happen. I will speak, though, to one issue, and I probably can't get in any trouble now for this. I would say that one area that I specifically noted in all of our work that I felt was lacking, if you will, in all of the recommendations, and again, there were over 50 of them that were proposed, was work around housing. And it was, to me, it was an obvious, it was not apparent in any of the recommendations. It was not connected to the recommendations. And when Director Hamos was speaking earlier about that doctor's visit that doesn't ask the question about their mental health issues, I muttered to her, well, I bet that doctor also didn't ask if they have housing. And so in my world of caring about all of human services, I've come to understand that if you don't take housing into account, you're really missing the boat when you're looking at any kind of service delivery. And so we were given an opportunity to react publicly within this domain of the Transition Committee. We were given an opportunity to speak out and tell them what we felt was glaring and what was missing. And among a couple of the points that I made, I spent quite a bit of time speaking to the committee and to McKinsey folks and to the 3 co-chairs, even offline again, about how any of the initiatives that they speak about, if does not take into account housing, affordable housing, supportive services for housing, any of that, right? Any of the initiatives that they're going to bring forward and speak about in their policy is going to be lacking. So I don't feel I can get in much trouble because I was pretty obvious with that and pretty vocal with that during the transition meetings. So I hope that answers.
Since we are among friends, I'll repeat rumors. That I've heard a lot of talk that the transition team is kind of disturbingly focused on plans for cuts. Which relates to the remarks I made earlier. Yeah, we have to focus on the budget. We have to be strong about adequate revenue to avoid significant cuts to important programs.
I think the point. The point though about collaboration, and what I wrote down my note as I heard you say that was interagency coordination. That's what I did for 6 years, was work very closely with the state departments of Children and Family Services, Healthcare and Family Services, Department of Human Services, Department on Aging, Department of Public Health. Letitia's here, knows how important that collaboration is. We did it as well with Department of Corrections because 30,000 people a year come out of corrections back into the community, as well as the Department of Financial and Professional Regulation. And I wanted to mention the Illinois Housing Development Authority is part of that conversation too, because they seed the developers to develop the properties, and then we have to figure out how to integrate those properties into our care system. And we never could before, but we can now, and there is absolutely no way you can comply with the consent decrees helping people leave institutions that they don't want to be in and move into the community unless you're focused on housing. And to that extent, to that end, we uniquely, I think, there aren't very many states that have ever done this. We have 3 statewide housing coordinators working out of the governor's office just to make sure that their resources are available to all of the state agencies that are engaged in the process of helping people achieve their highest level of independent functioning and living in the most community integrated setting possible. So I mean, it's become a very essential function, and it's something that only works if all of the agencies are working together to achieve what you accurately described as you can't send, but we'll spend hundreds of thousands of dollars on the medical care and then send people back to the street and wonder why they're not getting better. I can't imagine how a society develops that does that, but we can still do that routinely in our healthcare system, take care of the problem and then discharge the person back to the street.
Right, and just as yesterday, John Fallon pointed out at another meeting that we might just spend the money on the medical care and then discharge them to the street, and we count that cost to the medical system, but we might also put them out into the street, and when they get locked up in jail or prison, we don't count that as part of the cost to the healthcare system in most cases, so we mask that cost to the healthcare system. And that's, several people brought up access to care for people who are just as involved. And I think that was a really good point that I don't see John here, but that he made yesterday. So when we are talking about how we're spending the money, sometimes some of it is hidden. So the Alliance for Health Steering Committee meeting and webinar. But I wanted to give John Fallon credit for that comment. So we have a couple more questions lined up, and I think lots of fodder for discussion. So feed it.
I'm Kirshner. I'm a physician in rehabilitation medicine, and I wear several hats. I care for people with complex neurologic disabilities. I also have been working with the Community Care Alliance from its roots, and I've been a board member of Access Living. So I have all of those hats, but the hat I'm wearing right now as I ask my question is a medical educator and someone that's really concerned about the pipeline and the training of our healthcare workforce. We know that physicians are still coming out of medical school with about $200,000 of debt. We know that they're also not still being trained to practice the kind of health care that we're talking about. We are doing a better job with our nurse practitioner workforce, our physician's assistants, but we are talking about such a radical change in the way we should be training people if we're going to achieve this vision of medical home or health home care. We know that we've got serious problems in terms of the mental health pipeline. Half of our counties in Illinois don't have a psychiatrist. So my question is, what's being done to address that particular issue? You know, federally, many years ago, we had the National Health Service Corps as a way of trying to incentivize people to go into need areas to practice. Are we doing anything to incentivize primary care, mental health practitioners, and training people to practice in coordinated teams that think about housing and social determinants and this whole person, which really requires a very different mentality and a very different allotment of time and discussion. So if we're having physicians now having to interface with care coordinators at managed care organizations, are we teaching them how to best use those resources? I don't think we are, and I think it's a critical issue as we think about this restructuring. So I'd be curious if folks have any ideas about that.
I don't know if you were involved, but for the last 6 months, we did have a workforce work group under the direction of Dr. Lamar Hasbrook, the Director of Public Health, and Dr. Welch from the Rosalind Franklin Institute that led a very thorough discussion about those very issues. And this report to which I referred earlier that's available does have quite a bit of background and recommendations. I don't know if Letitia wants to say anything about that more from the Department of Public Health, but yeah, it's a huge problem. I mean, we completely agree, and that was in our recommendations from the Alliance for Health Innovation Plan last year, is that we not only have doctors graduating with this enormous debt, but they're graduating often in subspecialties that are not necessarily going to help at the primary care level, and they're not incentivized to work in areas of the state where there's already healthcare shortages. They're kind of discouraged from working in those areas. So we recommended expansion of these loan repayment programs and some restructuring of the graduate medical education process so that we could students come in wanting to do primary care, but they come out as super specialists, in part because of that huge loan obligation where they think they can make more money more quickly, not in primary care. So we have to change those incentives. Integrated delivery systems is another way to do that, because if you hold systems accountable for outcomes, primary care becomes much more important than it does in a fee-for-service environment where you will pay doctors based on skills and not on cognitive abilities. So that is all part of the same package, but it's very thoroughly addressed. Now we have to have both the will and the money to implement those policies. And as Director Hamas said, and we talked earlier, the 1115 waiver specifically seeks federal support for funding some of these innovative programs to get doctors practicing in primary care and practicing in inner city areas and rural areas across the state, and in the specialties that are needed right now. Yeah, please.
Well, yeah, but, okay. Recommendations are recommendations. Great. We've been making recommendations for a long time on these things. I will tell you that we just went through a very extensive hospital rate reform process at our agency, and had all the hospital stakeholders at our table. And when we, as an agency, had the audacity to suggest that the graduate medical education dollars ought to be targeted to training of primary care docs, guess who fought it? The med schools, okay, the hospitals that have med schools. So the exact, they still want to train specialists, and they didn't want to see targeting because they want to do what they want to do, and they want to still attract people who are going to become specialists. And when we went to Springfield last year, and Senator Heather Staines especially is very strong on trying to get independent practice for nurse practitioners. It's something we've been talking about only for about 10 years, 15 years? 15 years? And now it's become, and now it's more important than ever. Guess who fought it? The State Medical Society. Gee, what a surprise. They've been fighting it for 15 years. So, and it didn't pass, and it has never passed. So it's one thing to talk about this and to make recommendations, but the truth is the political will is completely lacking as I see it. And nobody really is looking at this long term. And when Dr. Ram Raju was here at Cook County Health and Hospital System, and he is a surgeon, and he was just fantastic about telling stories out of school. I love that guy for doing that. And he talked about being on these various certification boards for specialists, surgeons. And he said 15 years ago, we knew there was going to be a shortage of docs. We all understood this. And there was a real look at this by the medical profession itself. And guess what? They didn't do anything about changing the pipeline or doing anything about the pipeline. And then he would say, and guess why? He would say publicly, and then he would go like this. So the medical profession itself, I think in some ways has suppressed the pipeline, has not wanted to expand it, is still just as threatened as they always have been. I can't imagine why. There's so much business around. So we complain about people not having access to health care. Why isn't there more generosity of spirit about that and expanding what we really have always done? Why are we sticking to the status quo? So I'm not as excited about just seeing more reports with more recommendations until we figure out how we're going to really change that paradigm.
That's right.
The Institute of Medicine published a similar report, recommending that the GME positions be reallocated towards need-based areas. I would say that I would separate the hospital interest from the medical school interest. Sometimes they're the same, sometimes they're not. And GME does tend to be in the hospital. So I think that the interest groups and what they might be open to is variable.
I participated on the pipelines group that Michael referenced and was part of those recommendations and reports. And what I'd like to recommend is that we take a posture of educating and informing. I think it's going to be critical for the new administration, whomever gets hired to the different agencies, that we become the voice of educating and informing and letting them know what work has been done, what recommendations have been written, what politics have intervened in terms of not being able to get change done 10, 15 years in the making, and put it upon them to see what they are interested in taking on as action, because one of the things that they're looking for is to make their own mark. So let's give them something to make a mark for.
Yes, I just wanted to talk about kind of a niche area in workforce development. I think there's a greater role possible for peer advocacy and trained peer workers. I think in the mental health movement, we've seen community recovery support specialists play a really good role in helping people address issues that maybe their psychiatrists and psychologists don't have time to address, and sometimes serve as role models and such. Also, I know Illinois has moved forward with community health workers. I think that's a good thing. Yeah. And right now, Access Living, RIC, CCAI, and UIC are involved in a NIDER grant to help train peer health navigators to help people with disabilities maximize their access and understanding of their health care. And while it's a research project, we think it has great potential, and that would be a good thing. And then just something I heard the other day, which I think is kind of important, is, and the health plans were the ones saying this, and it says that, health consumers respond a lot better to their doctors than their health plans when it comes to phone calls and mail and all that sort of thing. And, it's a question of, I think, building trust with the case coordinators and having, some peer workers kind of help make that bridge, I think could be a very important part in doing that. And I'll just leave it at that.
Yeah, thanks. And thank you, Dr. Kirshner, for bringing up workforce. It was actually the third most popular priority identified in the registration forum when we asked for people's priorities, and included CHWs came up, community health workers came up. And I just wanted to tie this back a little bit to Deb Hamilton's story about her difficulties. That every step of the way, when she had a problem, there was a workforce issue. There was an MCO staff person that let her down, that maybe wasn't trained properly or wasn't doing the job that we expected when we launched this program. There were DHS staff that seemed to have let her down even before managed care. There were probably administrative staff she expects to be overseeing the program better that let her down. There were care coordinators, care managers. Tom mentioned some care people have experience, care managers that aren't informed about the person they're talking to. And so I think there is this workforce piece is so important because we can talk about blueprints, whether it's for rebalancing or for single payer or for coordinated care. But when the rubber hits the road, there's a human being trying to implement that. And if that human being doesn't have the right training or the right sort of perspective on the work they're supposed to be doing, if they think of themselves as a cost control mechanism instead of a quality improvement tool, then not that people are mechanisms and tools, they're people. But that's where it falls apart. And if you had the system you could imagine under which we could do better, we won't unless we have the right people, right? And that goes from doctors to nurses and what their scope of practice is, and community health workers and peer support and self-advocates, right? So I think that becomes so important because it's easy to just assume that there's this workforce out here that will do it. And the blueprint is just a chicken scratch if we don't have the people. So thank you for bringing it up. And for the people who brought it up on the registration.
Sharon, can I add one more thing really quick? So in the spirit of sort of looking forward, and this isn't increasing access to medical care necessarily, but it is increasing access to oral health care, which is just as important, hasn't been brought up. There's been a bill, and there will be another bill coming up this session to increase access to oral health care through allowing dental hygienists to practice at the top of their license. So I just encourage us all to sort of pay attention and look out for that and support it, because that does increase access to oral health care, which is desperately needed across our state, both sort of inner city in Chicago and especially in rural areas. So I just wanted to put that plug in. That's like one really tangible way we can work together in the next session to increase access to oral health care at least.
So I'm Scott again, and from Access Living, and I come with more comments, welcome responses, but I think there are more comments and seeds for the future. There's a limited scope to what we're able to do with the Ombudsman program. We're able to work with folks who are in the community care program, as well as MMAI, the Medicaid Medicare Alignment Initiative, but we're not able to work with folks in the integrated care program because of a lack of funding. So if the contract is extended in the future, I would like for us to be able to include that important population as a group of folks who benefit from that oversight, from that advocacy one-on-one, as well as systematic, because what we do with Tom is we work one-on-one to solve these issues with MCOs and DRS and what have you, but then we take that, and once we find a pattern, we take that to Tom, and he establishes what needs to happen at a policy level. The other comment that I have, I'm going to step out of my Access Living role and go into my 18 years of professional personal attendant service role, working in homes for people with disabilities as their personal attendant. And it hurts my soul. It hurts my soul that despite this effort to provide a holistic, is what the words I'm hearing, a holistic vision of service for our consumers, I, as a provider, am restricted to what's on the service plan. And if I go beyond what is on the service plan, I'm accused of fraud, or my employer is accused of fraud. We get threatening letters and things of this nature. My challenge, and it really just more planting a seed, as a provider, I want to be able to help my employer, as an extension of their body, to help them have sex with their significant other, to help them be a mother or a father, to be taking care of their pet, things of this nature, that if I'm doing it now, I or my employer get a threatening letter saying we're committing fraud because we're doing what's not on the service plan. So, and I find that to be discriminatory, because what this says is, people with disabilities can't have sex, can't be mothers, can't be fathers, can't be human beings. And so when we talk about this holistic vision of service, my challenge is, I don't know if it's on the service plan, I don't know where it is, but somewhere in there, I, as a provider, and as I age into my own disability issues, I want to know that I can still be a part of this human species and enjoy all of the things, the nuances, that we all otherwise get to enjoy.
Hey Scott, the first question. How long was your contract to do this ombudsman?
3 years, we're about 6 months into it.
So we're safe that you have a contract for the next 2 years, right, to take care of her problem? Got it.
Well, and we're limited in what we're able to do. That's another thing too, and because we're building the plane as we fly it, is the phrase being bandied about. And so we're learning there's restrictions that we're trying to, we have our own barriers, trying to work with DHS with their consent forms versus the consent forms that we have folks sign, trying to educate the managed care organizations on what we do so that we can get through their barriers that they have set up. And right now it's just as simple as getting a phone call back, which is what our consumers are dealing with too. So it's, you know, the same problems that our consumers are facing, we're facing too, but we've got a little bit more teeth. And we've got people like Tom who know people like you who can get things done. The other little thing that I'll just plug this, my job title is Resource and Training Specialist. So I'm not just an ombudsman. My job, I get paid to come to your house and educate consumers, providers, what have you, on what it is we do and how we can impact the consumers that you work with and serve.
Well, I want to see people's responses to what Scott said, and I especially wondered to what extent people think that, or know, or believe that the new rules from the federal government on person-centered planning for HCBS waiver services might address some of those worries about the service plan being sort of a cage and it being sort of, you know, care plan centered instead of person centered. I mean, we do have new rules we're obligated to implement, and I don't know to what extent they address the Scott's issues and difficulties and soul hurting, but it might be something if someone has a perspective on how that might change the way people are receiving and providing services.
Well, I wanted to, I can address that a little, but I also wanted to say that you, as has been noted, you know, we are among friends here, and that is a very eloquent description of what it, of some of the basic elements of being human and getting the support and the assistance you need to be a full person, which is what our programs are intended to help accomplish. But when we leave this room, you know, the job, it seems, for all of us is to make sure that the public recognizes that as an essential part as an essential human right and as an essential part of being a person, and that the public supports government dollars being used in that fashion. There is not, I think, consensus in the General Assembly about some of those functions being something for which the state taxpayer should be paying for, and so our job is it's fine to focus on the government, but government can only do what laws passed by our elected representatives allow us to do, and the idea of paying for that, I think, is something that there are a lot of folks outside here would balk at very, very vigorously. So, and we do. So I think our job is to take this message to our friends and neighbors and wherever we might have some influence, and make sure that people recognize that those sorts of aspects of human living are very important, and if we're supporting people, we have to support them in all of those ways. We do, in fact, do that a little bit for some of the people coming out, coming out of institutions. Their care plans do include those social factors, and it's just a normal part of living, and it gets done. But I think if those were highly publicized and used in the wrong way, as many people running for office would likely use them, we would end up losing support for those programs, not gaining it. So we really have a lot of work to do in the broader public to make sure that there's support for what we know should be done.
May I jump in right on that? Because that's actually what my question, so, you know, we keep saying that we're among friends, And the good news is we've been among friends for the last 6 years. I mean, Dr. Hamas, what a joy it was to have you at the helm, and doing this work. This entire system has changed under your leadership. I think in aggregate, it's significantly changed for the better. I mean, I came today to hear more about this transition, where quite frankly, don't tell anybody I'm saying this, we're not going to be among friends. And different people are going to be in leadership positions, and regardless of the laws, it's the implementation, I think, where we're really going to see the rubber hit the road. So I'm Leslie Romick. I work with the Illinois Association of Free and Charitable Clinics, and I work with people who are still in the cracks, who haven't even made it into the imperfect system that has been improved. What the hell are we going to do? I mean, seriously, this is a huge, big deal. And I think the budget is a huge part of it that John's been talking about. But I have this real fear, and I don't mean to sound like Cassandra, but I think we're on the verge of being screwed. And what can we do best to preserve the gains that have been made? And is it even possible that we're, the waiver, et cetera, that we're going to keep making gains? I hope. Thanks.
Could I piggyback? What's going on with the waiver, what she just asked? So is everything gonna go, because these guys have a 2-year contract, everything's no, John, earlier you said, they're not gonna move anything backwards, that we're too far along on the trains out of the track, out of the depot. What's gonna happen with the waiver? Could they pull it? Pull the request?
Yeah.
They can't. Is that what we're waiting to find out?
Yep.
It's not the feds, it's the state. We're waiting to find out if the state's gonna pull.
I mean, an 1115 Medicaid waiver is a very big undertaking for a state. It requires a huge commitment by a governor and by the department heads of the cabinet of a governor. And this new governor is going to have to really reaffirm all that for this thing to move along. And I don't think the feds will pay any attention to the state of Illinois until that really happens. Now, again, I think there are some practical reasons why Governor Rauner should embrace this. It does provide some more federal dollars for exactly the kind of community services we've been talking about. Community services, again, are not just a nice thing to do. They're kind of essential to the framework of how we're providing health care under Medicaid. And the managed care entities that we've created, any number of them will say that. They will acknowledge that because they're building a base, a system that requires community services, and they see the lack. There's a new voice of advocacy, if you will, from a very different group out there that's trying to build this kind of network, but know that there's a lack of services. So I think I would suggest as a strategy, really linking arms with the managed care entities instead of spending a lot of time trashing them. I think linking arms with them and seeing them as a force that could be helpful in moving that along. They acknowledge now that they have to change direction. They have to provide a whole different kind of service category than they've ever done before in their world of providing commercial health care. So linking arms with them and getting them together to move toward the 1115 waiver would be one of my strong suggestions today, because I think it will lead us in a better direction with some more funding for the state of Illinois.
So Julie, you're saying these MCOs, they should be pushing for the waiver too.
Correct.
And they're big business people.
Correct. And the hospitals are also a strong advocacy force. So we aligned, I think that we've aligned the forces in a way that this can be moved. But it's got to be moved now across the finish line to get the new governor and the cabinet to reaffirm that. And I think it's ready to go. They're all there. I mean, with the kind of stakeholder involvement that Michael Gelder and GoHIT have built, it's ready to move in that direction. But now it's going to be stopped unless there's that kind of push forward by all those stakeholders that have been sitting at the table.
Yeah, sorry. I had a few comments on that. I think, again, the economic inequality, we live in an age of austerity. For 30 years, we've been trying to cut the role of government, and that has impacts. That has effects on real people's lives. And, austerity means that really the very, very wealthy and the corporations are not paying their fair share of the taxes. And so, we talked about the revenue side. It seems, though, that you would have to address this, at least to some extent, with a social movement. The other thing I just want to mention that's very specific for the disability movement is that Governor-elect Ronner, in his previous business role, was heavily invested in nursing homes. And that concerns us. Is that the model that he wants to invest in Illinois? We don't know. And I think it's very important, if people have a chance to educate him or any of his people or legislators in general, that we need to talk about how, community services are what people want, that they end up being cheaper than institutional care, and that, this is the future. This is the way things need to go. So, this is a very specific concern that we have.
I think Judith had something to add on this topic.
So I think there's one area that has not changed in any of the conversations, and Michael alluded to it, and that's the General Assembly. And I think it is really more critical than ever if you're talking about what can we do rather than feeling helpless, like we can't do anything. I think this is the opportunity to talk to both sides of the aisle. We've heard for the last, I don't know how many years, from the Republicans in the General Assembly that they have felt that they couldn't do anything, that they were helpless, that they were being told or would vote no just unilaterally. And I think we have an opportunity now where they have an ally in the governor, and therefore it is our responsibility to make sure that we're conversing with them as much as we've ever conversed with what we typically have done, which are our friends in the General Assembly, and they have more power now because they have a governor that they are being listened to. And so I think from an advocacy perspective and an educating perspective, we don't want to forget that. We've built a phenomenal advocacy network over the last number of years, most specifically under the Governor's Office of Health, Innovation, and Transformation work that's been done, where we have listservs of hundreds of people who have participated and gave of themselves on these various work groups. Let's not lose those people, and let's not lose within ourselves the opportunity to see this as an opportunity. Yes, there's a battle. We've got a budget. We've got language that we hear from Governor-elect around waste, fraud, and abuse. I won't lie, that was a theme of our transition meetings. And so we need to be educating them. We need to be helping them understand. So if we think about what we can do, I'd like us to leave here today on a positive note of can do, not a negative of what we're being, confronted with next Monday. But we are together. We care about the health and welfare of people in Illinois. That's our role and our job and our mission. Let's not lose that. Let's keep moving forward with both sides, right? The new administration that comes in, educating them who will be the new directors, and maintaining our relationships, strengthening our relationships with the General Assembly. I've spoken to many Republican legislators in the last 2 months. They're excited. This is an opportunity for them. Let's not lose that opportunity to get them to be able to help us move forward as well.
I just realized I was making those faces on TV. And I guess you can do that a day before you're fired, so.
I think you resigned, dear.
You resigned,
yeah. They didn't fire you.
Hi again. Barbara Shaw asking about children's mental health. In the same vein that Mary asked about what's happening with the waiver, the 1115 waiver, I'm really interested in what's happening with the NB lawsuit. I mean, how much of that is going to be left to future negotiations? Is there a settlement decree? Is there a settlement proposal in front of the court? I mean, where is that process?
In some ways, it's in better shape because there will be a federal court and there will be a court monitor, and the state of Illinois is going to have to do something. But there is not a settlement decree yet, and it hasn't gone that far. I think if, and it's funny looking back on things, right? If we were further along with that lawsuit, I think in some ways it would be in better shape. But we didn't get that far. But I think, again, there was a lot of work done through the Go Hit work groups to really sort of lay it all out. So we would have needed that. We would have needed that time, and I think it's, again, perfectly aligned to move to the next stage. And the next stage really will be a settlement decree. Now, apparently, the court is kind of impatient about the fact that we're saying to them, the Attorney General is saying to them, hey, there's a new governor coming in, there's a new director coming in, they're going to have to decide what's in the settlement decree. And the court has basically said, look, we're going to hold you to some timelines here, and they're going to be pretty fast turnaround timelines. So get your act together, administration, and get something before us. So I think we're going to see action on that in relatively short time, I would say the next 3 to 6 months.
Quick comment on that. That's another thing to look at in the transition, is whether it in fact settles. The issue on cases like this, well, you can enter negotiations wanting to come to agreement, and you can enter negotiations wanting them to fall apart. And so part of the way that'll be a barometer on the new administration is, if that breaks down, why, and is there an intent there to actually put something in place that will help this area that's been such a problem for so long, children's mental health. Because there's ways to fight these things for many, many years. And hang them up in the courts and go to the Supreme Court and try to get it thrown out and so forth and so on. So I just think that that's probably going to be an early indication of the intent of the new administration.
Process though, right? I mean, what role can advocates play in understanding where things are, attempting to impact where things are, or is it such a internal legal?
Well, it's both. I don't think there's a formal role unless you're connected to the lawyers representing the plaintiffs. But I think you can put political or persuasive pressure on the officials who are charged with those issues. So whoever's the new HFS director, whoever's the relevant staff in the governor's office, ultimately the governor himself, to resolve these issues and talk about the policy more than about the lawsuit.
So we would be advocating, based on what Julie said, for entering this next stage based on the recommendations and the positions that have already been developed up to this point.
And to move it forward.
Yes, yes. So this is really an interesting set of questions and dialogue, because I'm just realizing that we don't talk about this as much, but the person representing the state is actually Lisa Madigan. And I think this is a good time to identify the attorney, which I will send out as an email today, who's representing us in NB, and start educating the NB attorney about these issues as well. And I think the NB attorney is pretty well up to date, because I think that this administration has been very much focused on settling and coming up with this system of care. Now, the selling point here to the Rauner administration, it seems to me, is that if they decide not to settle and decide to follow through with the lawsuit, we're going to lose. The state of Illinois is going to lose. And in part, it's going to lose because of something that I did, and I will confess to. We had families over the years that I've been here who came to us and said, we need our child in residential care. We need residential care for children in the Medicaid program. And we don't have a single one of these PRTF, psychiatric residential treatment facilities, they're called, in the Medicaid system. We don't have any in Illinois. And in part, I have kept that from happening because of all of my work. Tom will appreciate this, all of my work as a legislator and now as an HFS director on seeing how we overbuild institutional beds and don't pay equal attention to the community services that we need to keep kids out of institutional beds. So I was reluctant to do a building program where I knew, by the way, that all the nursing home operators would be lined up around the block to get into children's residential care. gee, what a great new market, right? And I was reluctant to start a single one of these PRTFs without seeing that community-based system of care developing equally at the same time. And we never were really able to do that until we had NB. So when we go into court to fight against a settlement that incorporates the big system that we need, we're going to lose, and the courts are going to make us build PRTFs. And that is not what we want, and that's not what the Ron administration should want either, because they're very expensive, and it's a building program that you know, in Pennsylvania, when they went down this road, pretty soon they had 700 beds. And guess what? They're filling them with kids. You know, and the states that resisted building PRTFs or had very limited number built up their community side and figured out a way to work with children and their families to provide sort of this system of care. So Lisa Madigan, strong advocate should be, and I think convincing them that this is financially not sustainable or desirable, and looking at the rate of, you know, the investment, what am I saying, the ROI, return on investment here in building up the community side, which is really seriously lacking for children.
Thank you for all that. I mean, I heard you say earlier that this is going to be a driver for what our system of care looks like, so thanks.
Yeah.
And I would just put another plug in, the outline for what we need to do to settle the suit on a positive basis is in that report that's now available, and it reflects thousands of person hours of work by advocates and providers and community organizations and parents throughout the spectrum of children's mental health needs.
Good morning, everyone. My name is Tamala Malin. I work at Access Community Health Network as a maternal and child community health worker. I also sit on the board for Health Connect One and EverDrive of Illinois, and I was recently elected to the Illinois Community Health Worker Advisory Board. I'm glad to wear those hats, but I appreciate this conversation, and some of the things I wanted to just comment on was about community health workers and about the bridges that they can sort of help in all different avenues when it comes to educating consumer of services. As someone who had to navigate many of these systems over the years, as a parent, and then as someone who provides, you know, that education to people who need it the most. I love when we talk about recommendations. I feel my charge now as someone, so I'm a mother of 6. I stayed in public housing. I work for a wonderful agency today, but it's because of my experience in working in the community and for the community and being a part of the community that I've been able to be passionate about this work. And I think when we think about making these work groups up, I've not heard a lot about people who are consumers of the services being at those tables. It's one of the driving reasons why I am still at the table. It's because I was asked to be at tables where historically we've not been asked to be at, because our voices are not always understood or heard, because well, we don't understand, you know, the financial and this is this, and you know, well, we may not know, but we consume the services. We understand what it is that we need. As a community health worker, I'm still crawling through cracks to find people and get them into care. And you know, we talk about why people don't do certain things like pick and choose. Choice is not always what we think it is from our provider point of view. Well, we offered this person a choice. Well, choice is understanding those choices. And that's why I think it's so key that we have put more substance in community health workers to educate people. I have young adults now. I used to have little kids, they're not little anymore. But I have young adults now who still need me to read over the choices. So I think that we have to remain cognitive that this is the problem with making choices and doing this work, because sometimes we forget that some of our community members don't always have the wherewithal to know that they have the right choice, or there's a real choice or a tangible choice that they can make when it comes to their care and the care for their families. So that was just my comment. Thank you.
Well, I'd like to say thank you. I'm not responding to the issue of choice as much as to the role of community health workers because, again, we've done a lot of talking about them. We recognize them, we value them, we applaud them, but we're trying to build a healthcare delivery system that embraces them and incorporates them. And I think we've done that with our new health homes. Health homes, when they become functional, 6 to 9 months, will, by definition, target the most complex populations, Medicaid populations, and will require the health plans to do outreach, finding our clients, outreach, engagement, getting that health risk assessment in place, engagement, and then high-touch care coordination. That's what that definition of a health home really is. So it's the outreach, engagement, high-touch care coordination. It's different than the other models of care coordination, and in my belief, the best suited to do those things are community health workers, being on the streets, in the streets, getting paid to look for people and getting them into healthcare. So we're beyond enrollment. We're beyond just the massive, fabulous work that we've done, in part under the leadership in my department of Mike Ketting, who is here. Raise your hand, Mike, in really embracing, he's been the deputy director for healthcare reform in our agency and implementation of the ACA outreach, the work that we've done in bringing 530,000 new Medicaid clients in, along with DHS, our sister agency, really a real collaboration. But again, now we're beyond enrollment. Now we're into the next phase of getting people into healthcare. And the health homes, I think, will be critical for the real high, complex populations. And I think we have found a way to pay community health workers. Now we need to get them into education, certified, and in the streets, and part of these networks.
I don't know if other people have immediate comments, but the comment about where the consumer is in the decision making reminded me that I had sort of tried to prompt if anyone wanted to speak to the new rules from the feds. This is another case of something that the new administration has to do, because it's not something that the Quinn administration pushed for so much as it is something the federal government is requiring of all states with home and community-based service waiver programs. And part of those rules is conflict-free case management, and part of it is person-centered planning. And the Governor's Office on Health Innovation and Transformation work group did a lot of work on sort of defining this. But it is something that a couple of the people sort of have described their the bad experiences they've had, but also the sense that the consumer is sort of marginalized, or the sense that a choice is simply a catalog of services that might not really even be responsive to what you need is presented to you, and that's not really a choice. And that's all things that this new rule is trying to address and that we must implement, whether the administration or General Assembly or anyone else likes it or not. We have to, and again, we can implement it more or less enthusiastically. But I wonder if anyone would want to speak to the extent to which those rules are being, where we are now in implementing those rules, where we might fall short, what's necessary from people in this room and beyond to make sure that they're not implemented in word only, right? And what we've done in the work groups in the GoHit work groups, because that's something where we have some recommendations and some proposed definitions of person-centeredness and things like that, that some people can start to implement in their own work in their own agencies, regardless of what the state does or the feds do. So is anyone comfortable speaking to these rules?
I don't want to speak to them specifically. I think some of the people out here know about some of the rules a lot, and up here know about some of the rules a lot more detail. But you're right. I mean, the overall point, I think, in terms of transition in this discussion today, and I'll reiterate what I said before, is that we really have to, this is a hearts and minds kind of question. We can technically try to comply, but there is still a very strong current of thought, ethic within many of our society that if you're going to get government money, you should have government people or government contractors decide what you need, and that is a challenge that we have to overcome. And that was the government program that I started working with in 2003 that we took over from 25 years of Republican administrations when I was at the Department on Aging, and that there was a very strong belief that the decisions about care should be made by outsiders and not by the people affected by the care because of what insurance would call the moral hazard. Like everybody affected by care is going to want more of it, and they're going to want more whether it's helpful or not, and that you need some limits that government or government contractors can provide based on rules that are set through a government-dominated process. So that thread, we tried to do as much as we could to put things back in the hands of people and families. We tried to encourage managed care by the amount of money they would have to spend to be part of the caregiving team, as Julie said before, make that they can be supportive now rather than engage in conflict with us. But there's still a lot of people throughout Illinois who don't believe in person-centered planning or people engaged in the process of planning for their care who are receiving government support for it. And we really have to work on them and their legislators to make this a reality ultimately, because I know we can do some things at the technical side, but if there's not the public support for it, it's not going to happen as thoroughly as we need it to happen.
Tom has a comment, if you could pass the small mic. Thank you.
Yes, I'd say Michael is basically right here, although public support is, I would characterize it a little different in that I think we would see great provider and state staff resistance to this because people don't like to give up power. And they're the ones that are often making those decisions now. And this new federal law, it's basically a civil rights implementation. And we know that civil rights laws are not always well enforced or followed. So I think it's really important that there be a significant education component to this, and that staff that work with people with disabilities and administrators and all sorts of people need to have a great deal of education about the importance of consumer control. You know, coming out of the independent living movement, I think we see that people's lives are improved, their health is improved, they live longer if they have more control over their own lives. And that's got to be the goal, and that's what we have to work for.
Important because it's actually better use of taxpayer money than he who pays the piper calls the tune, right? So thank you. I wanted to point out that I mentioned the GO-HIT recommendations around person-centeredness, and part of that was about implementing this rule, but a lot of it was about redefining the current HCBS services that we would be changing under the 1115. And we just talked about not knowing where the 1115 was going, but I think there's some really good language that got inserted in every definition about being person-centered. And we do have 1915C waivers that we've been extending, and if we don't do the 1115, sorry for all the jargon, we need to renew those. And I think there's probably, I'm not an expert on this, but there's probably room for people to advocate when we're renewing 1915C waivers, if we don't do 1915K or 1115, to insist that some of those redefinitions. Yeah, I'm sorry. I'm just talking to myself now. I'm talking to Scott too, I think, right? And Renee. But my point, I guess what I'm trying to say is, even if the 1115 falls apart, I think there's an opportunity to look at some of the language that really change some of this more bureaucratic professional defines the work to a person-centered plan kind of perspective, to put that into the to put that into the current system, even if it's not radically changed with the big 1115 waiver. So, and if people want to talk more about that, I love talking about sections of the Social Security Act. So, but let's move on for now, and we'll talk about that later with the cool kids. So, did anyone else have responses or anything about the comments about choice and person-centeredness before?
No, I had something on, it was the topic before that, about community health workers and workforce issues in general. And again, it's another sort of barometer thing to watch. We have I don't know how many trained enrollment, 600, 800, something like that, trained enrollment specialists, navigators, et cetera. 1,400 or so people are networked into Help Hub, which is a sort of crowdsourcing of good answers on that front. One question is, what will happen with that workforce? I mean, we don't have the big crush we had, but we still have a lot of eligible people who aren't enrolled. So are we going to maintain some effort on enrollment outreach? And then secondly, this is a workforce that has at least some level of training certainly on eligibility, but that there might be some ideas there about using that group to transition into some of the care coordination roles, case managing roles that we're talking about.
And continuing issues with the Medicaid expansion and enrollment in both Medicaid and the Marketplace was the 5th most popular priority from the registration form. So that's also something on a lot of people's minds, and especially that issue of sort of aligning the Medicaid and the private plans to the Marketplace, since there will be people going back and forth, and some of the plans are the same parent company. So this is definitely something that people could probably work together on. Tom, did you have a comment, or? Okay, so did Andy, you have another comment?
Yes,
okay.
Thanks. I have a couple of comments. I spoke before on Ann Sheets. First of all, I think that single-payer advocates are the only people who are realistic about the healthcare system. We know that as long as we have for-profit insurance companies involved in the financing of healthcare, they will screw us. They are infinitely capable of doing that. They are masters of fraud and abuse, and even the federal government is not able to prevent them from doing that, and there's abundant documentation of that in the Medicare Advantage program. Going back to the fee-for-service issue, which Ms. Hamos responded to, it is not the case that fee-for-service care is fragmented. There's a recent study showing that physicians working in small practices have a better record for preventing preventable admissions than people in large practices. The problem with fee-for-service is the networks. So I was a primary care physician for 30 years. I coordinated care for hundreds of people whom I saw in their homes, frail, elderly people who could not get out. For people on Medicare, regular Medicare, no problem, because my source of referrals was the whole healthcare system. I could send somebody to the Mayo Clinic or to Northwestern or to any specialist they chose, any hospital they chose. They could go to any pharmacy that they chose, and I could develop, and the patient and the family could develop a relationship with a pharmacist to make sure that their medicines got filled correctly. It was different with people who had only Medicaid because there's a limited number of providers who will take it. I did not have complete choice about where to send people. It is more difficult with the Medicaid managed care program, which has you cannot find a Medicaid managed care plan that includes your primary care physician, your choice of hospital, your choice of home health agency, and your choice of pharmacist. That is not possible. You can only have that if your network is the whole healthcare system. That's what we are fighting for. That's what I could do as a primary care physician when I took care of people on regular Medicare. I couldn't do it in Medicare Advantage plans either. I couldn't go see a patient down the street from me to do a home visit because if I ordered home health care for her, it wouldn't get paid for. That is what the single payer system, the single payer movement is fighting for. Physicians for a National Health Program is one group of physicians who are dedicated to the common good. And to end on a positive note, we know what we need. We're accustomed to both major parties trying to get rid of us, silence us. We will not be silenced, and we will continue to fight until we have a healthcare system that is not based on profit at all, but is based on taking care of people.
I work for health and medicine, and our founder always said, Quentin Young always said, everybody in, nobody out. So we do need to, I think, find a way to sort of operationalize that principle. So thank you for your comment. If anyone, I know that the network is often what comes up as a complaint about managed care. So I don't know if anyone in the audience or the panel wanted to respond to that, the sort of pros and cons of having these networks versus the wide open network, or if we, good, okay, so we heard you, and I think we have another question.
I thought I could follow it.
Right, yeah, that's the point.
My name is Kaliba Wilburn. I'm with Health Management Associates. And I really just wanted to follow up on John's preliminary Julius Caesar speech. And I don't know if this was brought up. I actually had to step out and I'm back. But if it is, someone stop me. But one of the things that I want to also applaud most of the folks in this panel and many of the people who have been working in healthcare reform and in the Affordable Care Act circles is all of the states' work on justice in health and access to health care for justice-involved populations. State of Illinois has been doing yeoman's work in that as well. We have enrolled so many people in our justice system into Medicare who were eligible for it. Many young single adult males who previously had not had access and who will now have access, and many of whom are the drivers of cost in our healthcare system. So I just wanted to take a minute to add that to the list of things that we've been able to accomplish, and to applaud our folks who have been working in those arenas, and also to add to the Julius Caesar speech. So thank you.
So we're down to, is it 15 minutes or so, Wesley, that we're down to? And I did we have, we could have people sort of wrap up. Oh wait, but we've got Letitia. Okay. Oh, introduce yourself there.
Sure. Hi, my name is Letitia Reyes-Nash, and I'm with the Illinois Department of Public Health. And I just wanted to take an opportunity. I missed a little bit of the panel presentation, so I apologize if this is repetitive. I just want to mention that, you know, I think that as we go forward, I think it's important, and you're seeing this across the nation, that we really change our perspective and look at improving health from a population perspective, and really looking at all of the resources and assets that we already have in our communities, and help to continue to build that capacity within our communities so that they can have healthier communities. And so it's really important to not only have a medical perspective in how we improve the health of our communities, but we have to look at where we live, work, and play, and think about how we can have interventions that work together, integrated, from the population level all the way to our individual delivery system, patient delivery system, and how do we connect all those dots so that we can achieve not only better health, but improved health outcomes, and also achieve those financial goals that we have as well. So I think that the trip lane has been discussed. I'm sure Michael discussed that as something, as a framework from which we work from, but please, you know, don't forget your local health department partners, your social service partners, your faith community partners. There's a broad spectrum of players to improve health in communities, and we can't just say that it's just the medical system's responsibility to improve health. We have to really have that community perspective, because we will not move the needle in health improvement if we don't address the problems that we have in health from a systematic community perspective. So.
This is the type of, if I can give a speech, Julius Caesar, that's the type of leadership that we've had from our Department of Public Health that I've been grateful for, learned a lot from, and been able to bring together a lot of those concepts of health, because we know medical care accounts for a tiny little fraction of that pie, and that the social economic determinants, the safety and healthy air and water and all those other determinants, the environmental determinants are much more important, and we have to attend to them, even though so much of our dollar gets directed towards the medical side. So I appreciate you raising that now, as you have over the last several years. So thank you, Letitia.
My name is Merle Sosa. I'm with the Illinois Psychiatric Society, and I just wanted to raise one issue that this whole discussion has been focused mostly on Medicaid, and I think that's obviously really important, but there's a lot of people who are covered by insurance, and that has hardly been talked about here, and this is supposed to be a forum on health reform, and so I feel that there's a lot of people who are now going to be on the exchanges as well as getting insurance. And so one of the things that Illinois Psychiatric Society is a district branch of the American Psychiatric Association, and one of the things that we're very acutely interested in is the implementation of the mental health parity laws. And so at all of the meetings where, the Go-Hit meetings, I kept saying, when are we going to discuss the implementation of the parity laws and making sure that people who have insurance know their rights under the parity laws so that we can make sure that insurance companies are doing what they're supposed to be doing under the federal regulations, which were passed about a year ago. So I think that's a very important thing that we need to talk about, because right now, a lot of people who have insurance are actually now going to be entitled to things that they haven't been entitled to before, and that can impact the ability, the state and what they provide. And I'm just going to give a really quick example, which is that under the federal parity regs, most people with insurance now can get residential treatment. And that's very important because before, many people who needed residential treatment for their children had to give up their children under custody relinquishment because their insurance wouldn't cover it. They couldn't get an individual care grant, and so they were left with nothing. And their child needed to get residential treatment, and so they were left with only one option, which was to give up custody of their children to DCFS. And so we at IPS have been working very hard. We helped pass a law last year on this issue. It wasn't as extensive as we would have liked. We're going to be working on another bill because basically the individual care grant money they are not paying for residential treatment. It's very, very difficult to get it through them. But parents need to know that they can get this care, and we have to make sure that consumers of insurance services know their rights. And so I think this should be part of health reform, and it hasn't been discussed at all during the session today.
With that, you're right. I think it's part of the sort of larger problem of network adequacy, and that largely sits in the Department of Insurance. So that's another place to watch, right? Who's going to be the director? What's their attitude? What kind of marching orders will they have from the governor's office? How in thrall are they to the insurance companies? And so I think that the playing field there is heavily on the certification process for networks and within insurance plans that are offered on the marketplace for the exchange. So I don't know if that's helpful or not, but that's one area to watch during this transition is who's going to be running that store.
Well, I totally agree with that, but even under the current administration, there hasn't been a whole lot of focus on this issue, despite our constant asking and trying to move forward. There just hasn't been a lot of movement on that. And I do agree with the network adequacy. I think network adequacy is going to be an issue whether you're on the Medicaid side or whether you're on the insurance side. I think that's going to be a very big issue as we move forward.
I think it already is.
And, you know, we all agree. The challenge, I think, will be with the new administration as with the current is how would you want us to go about doing that? What is it that isn't happening that should? What's the proposal that needs to be implemented to do that? Because we all fought for mental health parity, applauded when it happened, impose it as a requirement on our insurers in the state, and I think without knowing what else to do, we then hope for the best. But if there's something else that needs to be done, I think you need to be, you need to articulate what those actions are, and then hold the people accountable for whether they do them or not. I think some of my problem was always not really, well, what do we do about that? I agree with mental health parity is important. We know that insurers are probably not doing what they should, but that is a regulatory function of a industry's watchdog agency, the Department of Insurance, and we need to know what to react to. And they will need to know what you want them to do so they can react to it, and that we can, as advocates, keep putting pressure on for that to happen.
And I agree with you. That's one of the reasons why APA came out with a Patient's Bill of Rights, so that consumers, patients can know what they're entitled to and what they're not getting. And I think that's, hopefully we can distribute that widely so that patients know what they're not getting. And states like New York have actually moved the issue forward by having settlement agreements with, for example, Emblem Health and 2 other big healthcare associations requiring them to cover residential treatment and to cover other issues, plus make their services more transparent. So they've actually moved the bar forward. So it's a question of looking at that and seeing what other states are doing and then doing it ourselves. But I think it really starts with patients knowing what their rights are. And so hopefully we'll be able to do that. But also people have to be interested in advocating for this. And so that's why I wanted to make sure that this was an issue that I raised.
So what we talk a lot about not enough psychiatrists in Illinois, and I don't really, because I focus on Medicaid, I don't really know if there's capacity in the non-Medicaid world of psychiatrists. There isn't. So what I heard you now referred to a couple of times is more residential care. And I will just express the same concern I have on the Medicaid side and the non-Medicaid side. They're just building more beds, and the providers will fill the beds if we just build more beds. And without, people we have a huge number of people who go into psychiatric hospital care right now, and when they leave there 8 days later, what then? It's 8 days of filling a bed. We pay a lot of money to the hospitals to fill those beds, but they still need the community-based service component. So without building that up at the same time as we're talking about just residential care, will mean that we will again be overbedded in Illinois with institutional care. It's the same concern I have on whether you're talking about very low-income people or not very low-income people. It covers a person's needs for a short period of time, but when they leave there still needs to be something else to pick up the slack.
With all due respect, I do want to say something about residential care, which is, I was at a hearing yesterday on residential treatment centers, and there are a lot of really bad residential treatment centers here in Illinois. And so I think that there needs to be more oversight and better management of the residential treatment centers that we have, because kids have to go out of state to get good care. And I can speak from my experience because my daughter has been in a residential treatment center for 2 years. And it's a very excellent one, and she's received very good care. And even if we had the community services, she would not be able to have stayed in the community. She needed a residential treatment center to get better. So we do need those, and I'm just speaking from my experience that having enough or better community services would not have kept her out of the residential treatment center. She needed to be there, and 2 years later, she is now going to be able to go back out into the community next week. So I'm really excited about that, and I feel good about that. But there are kids who need residential treatment, and without it, they cannot live at home.
You get into a lot of realms of, what does it actually mean, parity with what? You've outlined some good ways to approach that in the political branches, the executive and the legislative, in the category of, if you've got a hammer, things look like a nail. It might be worth exploring whether that's an enforceable provision, that you could take into courts. Just in terms of network adequacy, whether to appeal a Department of Insurance decision to certify a network or a plan that didn't have adequate mental health services in it, or whether there's something that could be done with the insurance company itself. I don't know, but there may be some options there.
Well, thanks for bringing up parity. It came up a couple times in the priorities, and we hadn't really talked about private insurance, and it's a real challenge, I think, with mental health, that the only alternative shouldn't be to get on Medicaid to be able to get a full range of mental health services. And I'm actually really interested in implementing the parity law, and part of the reason to have these forums is to just hear other people and find out, oh, you're interested in that too, in my capacity in the Center for Long-Term Care Reform. So we should talk. And thanks for bringing it up, because it's part of reform. So, and we have possibly final Question or comment?
My name is Renee Popovitz, and
yes,
I'm
excellent.
an attorney at Popovitz and Robinson. I've had the pleasure of working with many of the people who sit on the panel, and I echo my appreciation for your service. I think you've made tremendous strides in terms of managed care, which we do need to have in this state in order to balance the Medicaid resources that we have. But I've heard a number of comments that I think people need to consider. In terms of Medicaid managed care, I don't think it's appropriate to say just because the company is a for-profit company that they're going to only be acting in the interests of that company. We have one of the largest not-for-profit companies here in the state of Illinois, Blue Cross Blue Shield. And if you look at their revenues, I think you need to take a closer look at it. And speaking of which, we have a wonderful director of the Department of Insurance right now, Andrew Boren. And I admit the first time I met him, you know, he came from the insurance industry, and I thought, oh no, he's on the dark side of things, you know, as a provider and someone in the community. And actually, he has done amazing things in terms of consumer rights. He has a division that has been focusing in on market conduct practices, and without having some of that data that we as providers don't know, how are we going to enforce our parity rights? So I think we need to continue having a state director at a Department of Insurance that focuses in on those consumer rights and is willing to stand up to the insurance companies if there are problems. In terms of parity, I know that we made some suggestions. We're looking at some ways we can improve the law here in our state. We passed a law in 2011. There haven't been a whole heck of a lot of complaints filed, and I think that that's partially because providers are afraid to bite the hand that feeds them, and consumers don't know their rights. So we need much stronger enforcement mechanisms. We need much stronger education. I think it's terrific what the Psychiatric Society has done in terms of education. I know there's behavioral health advocate listservs out there where they're constantly giving information. Our firm worked with the Illinois Alcoholism and Drug Dependence Association to put together a consumer bill of rights. The Kennedy Forum has started here, so I think that there's a real movement going on in terms of educating people, and I encourage you to look at those resources because this is just the beginning. Parity is a form of civil rights, and without education and enforcement, we're never going to see it. So I ask you to consider that.
That was an eloquent way to end, but we do have 2 minutes, so if anyone wants to try and cap that. We covered a lot of ground. We covered an awful lot of ground today. I hope that people learned a little and felt like they were hearing new perspectives. Thanks to the panel. Michael and Julie, I don't know, is this the last time you're going to be publicly in front of us as a part of the administration? Right, yeah. It won't be the last time we see them, but it's sort of an honor for Health and Medicine to sort of give them their last platform as members of the Quinn administration, at least. But certainly not as members of civil society in the public sphere, right? As the rest of us are. So it's been a long morning, and I thank all of you for coming out here. I don't know if you stuck around just because you don't want to go back in the cold, or if you stuck around because there was an interesting new topic that was going to come up. I hope we can all work together in the meantime, even if we differ on our sort of final goals. So thank you all so much, and I'll see you around. Yeah.